On a nuclear submarine, there is no doctor. There is one independent corpsman facing every emergency with only what fits inside a closet-sized medical bay. Millions of dollars worth of equipment and one vulnerable human body. If an infection turns dangerous or a sailor needs surgery, there is no hospital. It becomes a scramble for survival, and sometimes a midnight call for evacuation across distant seas. How does a submarine survive when help is hundreds of miles away? And what happens when things go wrong beneath the waves? Inside a U.S. Navy submarine, the medical bay is barely larger than a walk-in closet. The floor stretches only about 6 to 8 feet from end to end, and the width rarely exceeds 5 or 6 feet. Every inch is accounted for. Lining the bulkheads, narrow metal cabinets with positive latches keep supplies from shifting as the boat rolls through the ocean. The centerpiece is a single examination bunk, just wide enough for one sailor to lie flat, mounted tight against the wall. Above, fluorescent lights cast a harsh, steady glow, making the space feel clinical, almost stark, but never truly spacious. Space matters here. On one side, a small desk folds down, barely leaving room for the Independent Duty Corpsman to write notes or check a medication log. A compact medical refrigerator is wedged beneath a counter, holding temperature-sensitive drugs. Nearby, a double-locked safe secures controlled substances, with a bound logbook always close at hand. Open a drawer, and it is packed with neatly labeled boxes. Suture kits, bandages, syringes, and sealed packs of disposable instruments. Every tool has its place, from the manual blood pressure cuff and stethoscope to the digital thermometer and otoscope mounted on the wall. There is no room for bulky hospital monitors here, just a portable vital signs unit, a glucometer for finger-stick blood sugars, and a small microscope stored in a padded case for the rare urinalysis or quick stain. Order and organization keep this tiny space functional. Oxygen cylinders stand bracketed in the corner, each marked and inventoried before every patrol. The supply is finite, enough for a few days of low-flow therapy, and always rationed. Bag valve masks, airway adjuncts, and a basic trauma kit hang ready for the rare emergency. On a shelf, a handful of broad-spectrum antibiotics, painkillers, and common medications, antihistamines, gastrointestinal remedies, and sleep aids fill the pharmacy locker. There is no room for luxury or redundancy. Even the sharps container and biohazard bag are scaled down to fit in a space where two people can barely stand shoulder to shoulder. Supplies are limited by design. Lighting is all artificial, with a single task lamp above the bunk for exams at night. There is no window, no natural air, just the constant hum of ventilation and the faint vibration of machinery behind the walls. Surfaces are stainless steel or painted metal, easy to wipe down, but never quite spotless. Alcohol-based hand-rub dispensers and disinfectant wipes are always within reach. Everything is strapped, latched, or clipped to prevent noise and movement. The silence of the submarine is precious, and even a rattling drawer can give away the boat's position. Practice and restraint shape every action. This is the entire footprint for medical care at sea. There is no operating room, no imaging suite, no backup staff. The corpsman works alone, relying on these basic tools to handle everything from a sore throat to a broken bone. In this space, every decision matters, and every supply is precious. The reality of underwater medicine is defined by these boundaries: one bunk, a handful of instruments, and the skill of a single person standing between the crew and the unknown. Isolation is constant, and preparation is essential. Every medical supply on a U.S. Navy submarine is governed by strict rules, set long before the boat ever leaves the pier. These rules shape exactly what the crew carries and how it is stored. The Navy's Authorized Medical Allowance List, AMAL, dictates not just what can be carried, but exactly how much. There is no room for improvisation or overstocking. Each item, from antibiotics to bandages, is counted, labeled, and secured according to a fixed inventory ceiling. The corpsman is responsible for checking every line on the AMAL, confirming that the quantities match what is allowed for the size of the crew and the expected length of the patrol. If a submarine is cleared for 90 days at sea, the medical supplies must last just as long, with no option for resupply unless an emergency transfer is arranged. Storage is as much about security as it is about space. Controlled substances, including narcotics like morphine and fentanyl, are kept in a double-locked safe bolted to the bulkhead. Only the corpsman holds the key or combination with a sealed backup set under the command of the captain or executive officer. Every dose is logged in a bound ledger, listing the patient, the amount given, and the reason for use. Any discrepancy, even a single missing tablet, triggers an immediate investigation. Routine medications, such as painkillers, antibiotics, and antihistamines, are kept in smaller, clearly labeled bins or drawers, each with a tally sheet for daily inventory. Oxygen cylinders are bracketed and inventoried, with strict rules about how much can be used before supplies run low. Temperature-sensitive drugs are stored in a compact medical refrigerator, checked daily to ensure nothing spoils. Labels are more than just names. They are color-coded, waterproof, and resistant to smudging, so that even in an emergency, the right medication can be found in seconds. Cabinets and drawers are fitted with positive latches and locking mechanisms to prevent accidental opening during sharp maneuvers or rough seas. The corpsman reviews the entire inventory before every patrol, checking expiration dates and confirming that each item is within reach, but secure. There is no redundancy, no backup cache hidden away. If a supply runs out, the only options are rationing, improvisation, or requesting outside help. These inventory controls are not just about order. They are a doctrine of self-sufficiency. The AMAL is designed to ensure that every submarine can handle the most likely medical events with what is on board and nothing more. The rules are enforced with the same discipline as reactor safety and navigation protocols. In this environment, the margin for error is thin. The corpsman's ability to account for every dose, every bandage, and every vial is as essential as any other system on the boat. Once the hatches are sealed and the submarine slips beneath the waves, what is in the medical lockers is all they have until they return to port. Every independent duty corpsman who serves on a submarine begins their journey far from the ocean, in the classrooms and clinics of the Naval Undersea Medical Institute in Groton, Connecticut. The training pipeline is demanding by design. Before a corpsman ever sets foot on a submarine, they spend more than a year, 63 weeks, immersed in a curriculum that is equal parts medicine, submarine systems, and survival. The first 6 weeks are spent at basic enlisted submarine school, where recruits learn the language of the boat, how to navigate its passageways, master damage control, and understand the rhythms of life beneath the waves. This foundation is essential. Every corpsman must be a submariner first, ready to respond not just to medical crises, but to fire, flood, or any emergency that threatens the crew. Afterward, the focus turns to medicine. The Independent Duty Corpsman curriculum stretches for nearly 57 weeks, blending advanced clinical coursework with operational realities unique to life underwater. In the classroom, students study advanced physical diagnosis, emergency medicine, trauma stabilization, pharmacology, and laboratory basics. They learn to identify subtle signs of illness in the absence of sophisticated equipment, and to make decisions with only what fits in a duffel bag. Radiation health is a core module, reflecting the constant monitoring required on nuclear-powered boats. For 8 weeks, trainees study how to measure exposure, track contamination, and administer the ship's radiation health program, an everyday responsibility once they are at sea. Clinical medicine is the heart of the program. Over 44 weeks, Future corpsmen work through case studies and hands-on labs, practicing everything from wound closure and splinting to managing respiratory distress or severe infection. They gain experience in minor surgical procedures and learn to improvise when standard solutions are not available. The curriculum also covers preventive medicine, medical administration, and the logistics of running a miniature clinic, tracking immunizations, maintaining medical records, and ensuring every piece of equipment is ready for the next patrol. The training is not confined to classrooms. The final segment consists of clinical rotations, about 12 weeks spent in real-world hospital settings in Groton and Norfolk. Here, corpsmen rotate through emergency departments, sick call clinics, and inpatient wards, treating sailors and Marines under the supervision of Navy physicians. These rotations are where theory meets reality, where a corpsman must assess a patient, decide on treatment, and see the consequences of those decisions firsthand. Every skill is tested, from suturing a laceration to managing a patient with chest pain or a complex infection. Throughout the pipeline, the emphasis is on autonomy. There is no promise of backup at sea. Every corpsman is trained to act independently, to make the call when time is short and resources are limited. They qualify in advanced cardiac life support and basic life support, and must demonstrate proficiency in every aspect of submarine medicine before earning the right to serve as an independent duty corpsman. Submarine qualification is required as well. Damage control, watchstanding, and casualty response are as much a part of the job as diagnosing illness. By the end of the program, only a select group remains. These are the corpsmen who have proven they can shoulder the responsibility of an entire crew's health, alone and underwater. The pipeline is more than a series of classes. It is a crucible. The skills forged here are the only safety net a submarine will have, hundreds of feet below the surface, where every decision counts and every mistake carries weight. Every morning while underway, the Independent Duty Corpsman begins his rounds before most of the crew is awake. In the narrow passage outside the sick bay, he checks the atmosphere monitoring log for oxygen, carbon dioxide, and trace contaminants. A quick review of overnight watch reports follows, scanning for any mention of headaches, stomach trouble, or minor injuries. On a submarine, the line between routine and emergency is razor thin, so the focus is always on catching problems early. Vigilance is constant. Sick call starts just after breakfast. Sailors file through the cramped medical space, one at a time. Most complaints are familiar: a sore throat, a mild fever, a sore back from climbing ladders, or a persistent cough that will not clear in the recycled air. The corpsman listens, examines, and records each case in a handwritten log. He takes vital signs, checks for signs of infection, and dispenses basic medications: acetaminophen for fever, decongestants for congestion, topical creams for rashes. Minor cuts and burns from machinery are cleaned, bandaged, and documented. The Independent Duty Corpsman decides who can return to duty, who needs light work, and who should rest in their rack. For every sailor treated, he quietly tracks any symptoms that might indicate something more serious developing beneath the surface. Dental problems are a recurring challenge. Toothaches and minor gum infections are managed with antibiotics, saltwater rinses, and pain relief. The corpsman carries basic dental tools for temporary fillings or to smooth a chipped tooth, but anything more severe is a concern. Dental emergencies have forced submarines to surface in the past, so each case is watched closely. The crew knows that prevention is the best medicine, and daily hygiene is enforced. Prevention is part of the routine. Preventive medicine is woven into the daily rhythm. The corpsman inspects the galley, reviews food storage, checks water chlorination levels, and ensures sanitation standards are met. He walks through berthing areas, looking for signs of mold, poor ventilation, or clutter that could harbor infection. Hygiene is non-negotiable. Hand sanitizer stations are refilled, and reminders about cough etiquette and hand washing are posted in communal spaces. Any sign of a contagious illness prompts rapid isolation measures, even if that means confining a sailor to a single bunk in the already crowded berthing. Immunization records are reviewed before every patrol, and the corpsman keeps a running tally of who might need boosters. Fitness for duty is monitored informally. He watches for signs of fatigue, stress, or sleep problems, offering advice, or when necessary, a listening ear. Mental health is part of the job as well. In the close quarters of a submarine, stress and insomnia are common. The corpsman dispenses sleep aids sparingly and encourages routines that help the crew rest. For more persistent anxiety or mood issues, he offers support, keeps notes, and is prepared to consult with shore-based mental health professionals if concerns escalate. Care is both physical and mental. Every few days, the Independent Duty Corpsman runs drills, first aid refreshers for the crew, casualty evacuation practice, and checks of emergency medical kits stashed throughout the boat. Supplies are inventoried and reordered in the log, with careful attention to what has been used and what must last until the next port. When a sailor recovers from illness or injury, the corpsman updates the medical record and follows up to ensure there are no lingering effects. It is a cycle of routine and readiness, repeated day after day, patrol after patrol. Most medical issues on a submarine are managed with these daily habits. The majority of cases never escalate beyond a sore muscle, a cold, or a minor infection. The corpsman's presence is a quiet reassurance, a reminder that even in the depths of the ocean, someone is watching over the health of the crew. Reassurance is constant. The goal is always the same: keep everyone fit for duty, prevent small problems from growing, and ensure the submarine can complete its mission without interruption. In this environment, routine care and prevention are not just medical practices, they are essential elements of survival beneath the waves. Inside a U.S. submarine, the limits of medical care are set by the very structure of the vessel itself. There is no operating room hidden behind a bulkhead, no surgical lights waiting to be switched on in an emergency. The sick bay, already described in its detail and scale, is not designed for complex procedures. Advanced imaging, computed tomography scans, X-rays, even a portable ultrasound on some boats, are either completely absent or, at best, limited to the most basic handheld devices, if permitted by space and the current equipment list. For the overwhelming majority of submarines, there is no surgeon, no physician, and no specialist standing by. The only provider is the Independent Duty Corpsman, trained to handle a broad range of primary care and emergency stabilization, but never intended to perform surgery or manage critical care beyond the initial response. If a sailor develops severe abdominal pain that points toward appendicitis, or a traumatic injury that would normally require an operating room, the options narrow quickly. The corpsman can provide pain relief, antibiotics, and fluids, but cannot remove an appendix or repair internal bleeding. There is no blood bank, no anesthesia machine, no surgical team. Even simple diagnostics are limited to what can be done with a stethoscope, a thermometer, and a handful of rapid tests. The sick bay's single exam bunk is not a surgical table. It is a place for assessment, basic intervention, and, if needed, to stabilize a patient until a decision is made to seek help from shore. Every serious medical event forces the question, can this be handled with what is on hand, or does the boat need to break its isolation? The answer is almost always dictated by these boundaries. If a case falls outside the reach of onboard care, the corpsman must consult with medical officers on land, and the command must weigh the risks of surfacing and requesting evacuation. These structural limits are not just a matter of inconvenience, they define the stakes for every member of the crew. On a submarine, the line between manageable and unmanageable is drawn not by what is possible in a hospital, but by what can fit in a room no larger than a closet, staffed by a single, highly trained sailor. When a medical crisis exceeds the submarine's limited resources, the Independent Duty Corpsman turns to shore-based expertise through secure, encrypted communications. The process begins at a small terminal often wedged between racks of electronics or tucked in a corner near the radio room. There, the corpsman composes a detailed, structured message for Navy medical officers on land. Every consult follows a strict format, listing the patient's age and rank, symptoms and timeline, vital signs, exam findings, treatments already given, and a clear question: should the case be managed on board, or is evacuation necessary? The messages are concise and clinical, stripped of unnecessary detail, but packed with the information a distant physician will need to make a judgment. On a submarine, every transmission is a calculated risk. Mission secrecy often restricts real-time communication. The boat may wait hours for a scheduled communications window, or hold messages until it is safe to transmit. When the moment arrives, the medical consult is queued alongside operational traffic, encrypted with military-grade cryptography, and sent through narrowband satellite or high-frequency radio. At the receiving end, Navy doctors review the report, sometimes consulting with specialists, and draft a reply that travels the same secure path back to the boat. The reply may include recommendations for further treatment, adjustments to medication, or new diagnostic steps. In some cases, the guidance is blunt, instructing the crew to begin preparing for possible evacuation. Delays are common. Hours can pass between updates, especially when the submarine is under emissions control. The corpsman must anticipate follow-up questions, front-loading the initial message with every relevant detail to avoid costly back and forth. While the technology is advanced, the reality is often closer to store and forward telemedicine than to a live consultation. For the sailor in the sick bay, advice from shore arrives as a lifeline. Sometimes it comes just in time. Sometimes it is delayed by the demands of stealth and the rhythms of the ocean. Even with expert guidance, the Independent Duty Corpsman remains the only hands at the bedside, bridging the gap between distant expertise and the immediate needs of the crew. In the depths of the ocean, hundreds of miles from shore, the submarine crew faces more than just the technical limits of underwater medicine. The psychological weight of isolation presses in from every angle. For weeks at a time, there is no sunrise, no fresh air, and no escape from the constant hum of machinery. The air is filtered and recycled, the light is artificial, and the walls never move more than a few feet away. Sleep is rationed in short rotations, often broken by the need to stand watch or respond to a drill. Fatigue accumulates quietly, dulling reaction times and making even routine decisions feel heavier. When a medical emergency arises, the emotional strain spreads through the crew. Every submariner knows the patient personally. There are no strangers on board. Word travels fast in such close quarters, and concern ripples out from the sickbay to every compartment. The knowledge that help is far away, and that there is no hospital nearby, sharpens the sense of vulnerability. Yet panic is rare. Years of training and constant drills have ingrained discipline deep into the daily routine. In moments of crisis, the crew falls back on checklists and practiced procedures, moving with deliberate calm rather than haste. The Independent Duty Corpsman carries a unique burden. Alone in the medical space, they are both caregiver and decision-maker, aware that every call they make could mean the difference between recovery and disaster. There is no immediate second opinion, just protocols, memory, and the distant voice of a shore-based doctor when communication allows. To cope, the corpsman relies on structure, reviewing inventory, rehearsing emergency scenarios, and keeping meticulous records. These routines are more than habit. They are a shield against the creeping effects of fatigue and uncertainty. Throughout the boat, routines become anchors. Meals are served at the same times, drills are run with clockwork precision, and every sailor rotates through their duties in a cycle that rarely changes. This predictability helps blunt the edge of anxiety and keeps the crew focused on the mission. Even in the face of a medical scare, the submarine culture of discipline and mutual support holds steady. The environment may be isolating, but it is also one of quiet resilience, where professionalism and routine become the crew's best defense against the psychological strain of life beneath the waves. On a submarine, the decision to break isolation and call for evacuation is shaped by strict thresholds. The Navy tracks these events, sorting them into 3 diagnostic categories: injury, psychiatric, and medical, including dental emergencies. Each year, around 143 sailors across the U.S. submarine force are evacuated for reasons that fall into these groups. The number is small, but each case disrupts operations, exposes the boat's location, and tests the command's resolve. Injury is a constant threat in the cramped mechanical world below the waves. Fractures, deep lacerations, head trauma, and crush injuries from machinery or ladders are rare but always possible. The Independent Duty Corpsman can splint limbs, control bleeding, and manage pain, but when internal bleeding or a complex fracture is suspected, the limits of submarine medicine become clear. Without imaging or surgery, evacuation is often the only safe option. Medical emergencies can escalate quickly. Acute abdominal pain, especially suspected appendicitis, remains a classic submarine crisis. Persistent, severe pain, fever, or signs of infection that suggest a rupturing appendix force a hard choice. Antibiotics and fluids may buy time, but there is no way to remove the organ or treat peritonitis at sea. The same urgency applies to severe infections, sepsis, deep abscesses, or spreading cellulitis. When a sailor's condition worsens, despite all available treatments, evacuation becomes unavoidable. Dental emergencies, though sometimes underestimated, are frequent. A dental abscess can quickly sideline a sailor, robbing them of sleep and the ability to perform duties. The corpsman's tools are limited to basic dental kits and antibiotics. If swelling spreads or the sailor's condition deteriorates, the only recourse is to surface for extraction. Psychiatric emergencies form the 3rd major category. Acute psychosis, severe depression, or suicidal thoughts cannot be managed with medication and vigilance alone. The isolation and pressure of submarine life magnify these risks. If a sailor becomes a danger to themselves or others, the safety of the crew takes precedence. Here, the corpsman's judgment is critical, and the decision to evacuate is made as soon as it is tactically possible. These critical triggers, injury, psychiatric crisis, and medical emergencies, force submarines to break their silence and seek help about 143 times a year. Each case is a stark reminder of the balance between self-sufficiency and vulnerability, and the weight carried by the corpsman and command. When the threshold is crossed, the health of one sailor becomes the concern of the entire fleet. The decision has been made. The submarine will surface for a medical evacuation. Below decks, the Independent Duty Corpsman moves with steady focus, monitoring the patient's vital signs and double-checking every step. Oxygen flows through a mask. An intravenous line is taped to the sailor's arm. Pain is managed with what little can be spared from the tightly inventoried supplies. The corpsman reviews the care log to make sure nothing is missed. A small team is briefed and everyone knows their role. The route from sickbay to the escape hatch is cleared, ladders are checked, and the stretcher is readied. In a space where 2 people can barely stand side by side, the patient is carefully strapped into a rigid litter, bundled against the cold that waits outside. Up in the control room, navigation officers plot a course to the nearest safe extraction point. Weather reports and sea state are reviewed in real time. The commanding officer weighs the risks. Surfacing could reveal the submarine's position, but delay could cost a life. Orders are given, ballast tanks are vented, and the boat rises from the depths as the hull breaks through the surface. On the bridge, a topside detail assembles in helmets and life jackets clipped to safety lines. The wind is sharp and the deck is slick, but there is no hesitation. Inside, the patient is moved. At each ladder, sailors coordinate the slow, careful handoff, one step at a time, always watching for a slip. The corpsman calls out instructions, steady and direct. At the forward hatch, the escape trunk is prepared. Pressure is equalized. The hatch is cranked open, and cold ocean air rushes in. The litter is maneuvered into position, every movement rehearsed but never routine. Above, the thump of rotor blades grows louder. The helicopter hovers, holding steady in the wind. A rescue swimmer is lowered first, touching down on the narrow deck. The hoist cable follows, swinging in the wash. The litter is clipped to the hook, straps checked, and the tagline is held taut to prevent spinning. The corpsman hands over a sealed packet with patient details, treatments given, medication doses, and allergies, all written in block letters and waterproofed against the spray. On the bridge, the officer of the deck confirms with the helicopter crew. The hoist begins. The litter rises, buffeted by the downdraft, steadied by the swimmer and the tagline. In seconds, the patient is lifted clear of the deck and drawn up into the cabin. The swimmer follows. The helicopter banks away toward the nearest hospital. Back on the submarine, the hatch is secured, and the crew moves below, returning to their stations. The corpsman gathers used supplies, updates the medical log, and sits quietly for a moment before repacking the trauma kit. The submarine prepares to dive again, returning to silence and the deep. The operation is over, but the routine resumes. One sailor down, the mission altered, but the crew intact. Responsibility on a submarine, when a medical crisis unfolds, lands squarely on the shoulders of two people more than any others: the Independent Duty Corpsman and the commanding officer. The corpsman, alone in the sick bay, knows that every action, each dose, each word of reassurance, each decision to wait or escalate carries consequences that ripple through the entire crew. There is no backup, no second opinion at hand. Even with protocols and years of training, the corpsman feels the full weight of being the only medical professional for more than 100 sailors, hundreds of feet below the surface. Mistakes are not just personal. They could cost a life or force the submarine to abandon its mission. The commanding officer faces a different kind of burden. Every decision is a balance between mission and humanity. Surfacing for a medical evacuation can reveal the submarine's position, disrupt strategic operations, and put the entire crew at risk. But the alternative, waiting too long and hoping a sailor's condition will stabilize, brings its own dangers. The commanding officer relies on the corpsman's judgment, asking for clear, unvarnished advice. Can we manage this here, or do we risk everything to get help? These conversations happen quietly, often in the captain's stateroom or a cramped passageway, away from the rest of the crew. There is no room for bravado, only honesty and resolve. Inside the sickbay, the corpsman double-checks every step, reviewing the patient's chart and inventory log, replaying the last few hours for anything missed. Fatigue creeps in, sharpened by the knowledge that help is far away and time is running short. The corpsman's voice stays steady, but the mind races. Are the symptoms changing? Is the treatment enough? Should I have called for evacuation sooner? The sense of isolation is profound, even among friends and shipmates. There is comfort in routine, but routine is shattered by the gravity of the moment. On the bridge, the commanding officer weighs the tactical picture against the reality in sickbay. Orders to surface are not given lightly. The decision, once made, is final. A signal to the entire crew that the needs of one outweigh the mission, at least for a moment. Afterward, the commanding officer and corpsman both carry the memory of the crisis. For the corpsman, every emergency is a test of skill and judgment, but also of conscience. For the commanding officer, it is a reminder that leadership is measured not just in orders given, but in the willingness to bear the cost of those decisions. In the silence that follows, both know the true meaning of responsibility under the ocean. Beneath the ocean, a single medical emergency can force a billion-dollar vessel to surface, risking mission and crew for one life. Today, that calculation defines every patrol. As technology advances, prevention and remote medicine push the limits, but isolation remains absolute. In these depths, every heartbeat depends on trust, training, and the thin line between routine and crisis. The true test isn't the machinery, it's the resilience of the people inside. Thank you for watching.